as Isabel mentioned, and it's kind of important to wait. I mean, let's go back to the case. This is a patient where we've decided not to manage their oligometastatic disease aggressively. We're going to treat with either a TKI or with immunotherapy because they have both markers. What we've learned in the past 2 years is essentially that EGFR mutant lung cancer is not the right cancer for immunotherapy, at least single agent immunotherapy. We had a meta-analysis of 5 trials comparing immunotherapy to chemotherapy. We know immunotherapy is better than chemotherapy in second line, and the meta-analysis basically showed that overall trend, immunotherapy better than chemotherapy in second line non-small cell lung cancer. But if you looked at the patients that were in those trials that were EGFR mutant and looking at those patients, and the meta-analysis would suggest there's no benefit in the EGFR mutant. So that was kind of the first signal we got that we may need to pump the brakes on immunotherapy with EGFR mutant lung cancer. The second, perhaps more convincing and compelling data was presented at ASCO as an oral session in 2018, and then subsequently published in the Journal of Thoracic Oncology. It's a fascinating study. They basically took patients that were treatment naive, they were stage 4, roughly 20 patients, all EGFR mutated, and most of them were high PD-L1. And they basically wanted to ask the question, let's not give these patients a TKI, let's just give them immunotherapy and let's see how they do. Let's give them single agent pembrolizumab. They're all EGFR mutated, but they all have, 75% of them had high PD-L1 as well. You would think that you would achieve some responses in these patients that got single agent immunotherapy, given that 75% of them were also PD-L1 greater than 50%. And the response rate was 0. There was no response in these patients to single agent immunotherapy. In fact, there were some toxicity concerns with sequencing the immunotherapy followed by TKI. And the running joke from this trial, not that this trial was a joke, I mean, it certainly did solidify the lack of evidence for immunotherapy. There was one patient in this study that did have a response to immunotherapy, but in hindsight, they found out this patient wasn't EGFR mutated. So, it really does, I think, for us, alter our perceptions of immunotherapy in EGFR mutated lung cancer. It also, as Isabel said, I think, the problem, as Sam mentioned, is that the PD-L1 comes back right away. It's ready, but the EGFR may take 2-3 weeks. And so, and we've got that coupled with patient enthusiasm saying, hey, my PD-L1 is 50%. I want pembrolizumab. I've seen that drug on TV, it's immunotherapy. And I mean, I wish I could tell you I'm making this up, but this is what we see in our clinics. And we do, I think there is a role of the medical oncologist to temper the enthusiasm on immunotherapy, to say, wait, we've got to wait for some of these mutations to come back. I don't know, Isabel, have you struggled with patients really wanting it where you have to push back, or do they usually come on board and say, okay, I'm with you, doc. I can wait a little bit longer?
So I definitely have had patients coming in strong with the desire to get frontline pembrolizumab, or they mention Opdivo or any immunotherapy that they see on the television. But fortunately in my practice, I've not had patients that have been defiant to me educating them. But I anticipate that happening one day, and I think that having the opportunity to discuss liquid biopsy, to maybe use that to further temper them, may be a nice way to interweave that into my practice.
Yeah. I'm selfish. I want to defend myself, so I'm like, I'll just order this liquid biopsy real quick, get the result, so we'll have it within 5 days. And there are limitations, I think, that Sam, you highlighted eloquently with liquid biopsies that we still need to iron out.
And Ben, I would add, I think this is a great case that also kind of demonstrates some of the value that radiation plays in these patients, especially patients that are receiving some targeted agents like this. We've seen good data that's demonstrated that, patients who are either rendered into an oligometastatic state or remain in an oligometastatic state that are on targeted therapies, you're essentially putting a selection pressure on these patients, and they may develop or stay on stable disease. You can treat those sites of disease with stereotactic radiation or some type of local therapy, and they can stay on their targeted agent, and it can actually derive a significant progression-free interval, even and not have to change into a second-line or third-line therapy.
That's a great point. The selective pressure that happens, and then addressing those selective pressure sites with radiation, I think, is critical. And maybe this would be the way that I would manage this patient potentially is start them out on a TKI, see how they do. If they're doing well, maybe to layer in the radiation at 3 months or when they progress at those sites. I don't think we've clearly ironed that out yet, but I agree. I think there's a role in oligometastatic disease for EGFR-mutated lung cancer where you can continue the TKI while you're delivering the radiation, which I think is important.